Hello everyone. Welcome to the Global Health Education and Innovative Learning Forum channel. Myself Yuvarajan Subramaniam. In this video session, we would like to discuss the testing and diagnosis of tuberculosis, including who should be tested, testing for TB infection, testing in BCG-vaccinated persons, TB screening and testing of healthcare personnel, testing during pregnancy, diagnosing latent TB infection and TB disease, deciding when to treat latent TB infection, treatment regimens for LTBI, treatment for TB disease, adverse events, TB treatment of persons living with HIV, TB treatment and pregnancy, TB treatment for children, what is drug-resistant TB, causes and types of drug-resistant TB, and prevention and treatment of drug-resistant of TB. Before getting into this video session, please subscribe to this GHEIL Forum channel and share all our video links to your friends, colleagues, people who work in the development and healthcare sectors. Let us start the discussion. Testing and diagnosis of tuberculosis. Testing. There are two kinds of tests that are used to detect TB bacteria in the body: the TB skin test, TST, and TB blood tests. A positive TB skin test or TB blood test only tells that a person has been infected with TB bacteria. It does not tell whether the person has latent TB infection, LTBI, or has progressed to TB disease. Other tests, such as a chest X-ray and a sample of sputum, are needed to see whether the person has TB disease. Diagnosis. If a person is found to be infected with TB bacteria, other tests are needed to see if the person has latent TB infection or TB disease. Types of diagnosis for Mycobacterium tuberculosis detection. Signs and symptoms consistent with TB. Chest X-ray. Clinical judgment. Bacteriology. AFB smear microscopy. Nucleic acid amplification testing, NAC. Culture and identification. Drug susceptibility testing, DST. Who should be tested for Mycobacterium tuberculosis? Certain people should be tested for TB infection because they are at higher risk for being infected with TB bacteria, including people who have spent time with someone who has TB disease, people from a country where TB disease is common, most countries in Latin America, the Caribbean, Africa, Asia, Eastern Europe, and Russia. People who live or work in high-risk settings, for example, correctional facilities, long-term care facilities or nursing homes, and homeless shelters. Healthcare workers who care for patients at increased risk for TB disease. Infants, children and adolescents exposed to adults who are at increased risk for latent tuberculosis infection or TB disease. High-risk group for developing tuberculosis disease. Many people who have latent TB infection never develop TB disease. But some people who have latent TB infection are more likely to develop TB disease than others. Those at high risk for developing TB disease include people with HIV infection, people who became infected with TB bacteria in the last 2 years, babies and young children, people who inject illegal drugs, people who are sick with other diseases that weaken the immune system, elderly people, people who were not treated correctly for TB in the past, TB tests are generally not needed for people with a low risk of infection with TB bacteria. Testing for TB infection. There are two types of tests for TB infection: the TB skin test and the TB blood test. A person's healthcare provider should choose which TB test to use. Factors in selecting which test to use include the reason for testing, test availability, and cost. Generally, it is not recommended to test a person with both a TB skin test and a TB blood test. Testing for tuberculosis infection. Tuberculosis skin test. The TB skin test is also called the Mantoux tuberculin skin test, TST. A TB skin test requires 2 visits with a healthcare provider. On the first visit, the test is placed. On the second visit, the healthcare provider reads the test. The TB skin test is performed by injecting a small amount of fluid, called tuberculin, into the skin on the lower part of the arm. A person given the tuberculin skin test must return within 48 to 72 hours to have a trained healthcare worker look for a reaction on the arm. The result depends on the size of the raised, hard area or swelling. Positive skin test. This means the person's body was infected with TB bacteria. Additional tests are needed to determine if the person has latent TB infection or TB disease. Negative skin test. This means the person's body did not react to the test, and that latent TB infection or TB disease is not likely. There is no problem in repeating a TB skin test. If repeated, the additional test should be placed in a different location on the body, example, another arm. The TB skin test is the preferred TB test for children under the age of 5. Testing for tuberculosis infection. Tuberculosis blood test. TB blood tests are also called interferon gamma release assays or IGRAs. 2 TB blood tests are approved by the US Food and Drug Administration, FDA, and are available in many countries. The QuantiFERON registered trademark symbol -TB Gold Plus, QFT Plus, and the T-Spot registered trademark symbol .TB test, T-Spot. A healthcare provider will draw a patient's blood and send it to a laboratory for analysis and results. Positive TB blood test. This means that the person has been infected with TB bacteria. Additional tests are needed to determine if the person has latent TB infection or TB disease. Negative TB blood test. This means that the person's blood did not react to the test and that latent TB infection or TB disease is not likely. TB blood tests are the preferred TB test for people who have received the TB vaccine Bacillus-Calmette-Guerin, in short BCG. People who have a difficult time returning for a second appointment to look for a reaction to the TST. Testing in BCG-vaccinated persons for tuberculosis. Many people born outside of the United States have been given a vaccine called BCG. People who were previously vaccinated with BCG may receive a TB skin test to test for TB infection. Vaccination with BCG may cause a false positive reaction to a TB skin test. A positive reaction to a TB skin test may be due to the BCG vaccine itself or due to infection with TB bacteria. TB blood tests, IGRAs, unlike the TB skin test, are not affected by prior BCG vaccination and are not expected to give a false positive result in people who have received BCG. TB blood tests are the preferred method of TB testing for people who have received the BCG vaccine. Tuberculosis screening and testing of healthcare personnel. Tuberculosis screening and testing of healthcare personnel is recommended as part of a TB infection control plan and might be required by state regulations. For TB regulations in your area, please contact your state or local TB control program. TB screening programs should include anyone working or volunteering in healthcare settings, including inpatient settings, outpatient settings, laboratories, emergency medical services, medical settings in correctional facilities, home-based healthcare and outreach settings, long-term care facilities, and clinics in homeless shelters. Testing during pregnancy for tuberculosis. There is a greater risk to a pregnant woman and her baby if TB disease is not diagnosed and treated. TB skin testing is considered both valid and safe throughout pregnancy. TB blood tests also are safe to use during pregnancy, but have not been evaluated for diagnosing TB infection in pregnant women. Other tests are needed to show if a person has TB disease. Diagnosing latent TB infection and disease. Most persons, but not everyone, with TB disease have one or more symptoms of TB disease. All persons with either symptoms or a positive TB test result should be evaluated for TB disease. If a person has symptoms, but a negative TB test result, they should still be evaluated for TB disease. Diagnosis of latent TB infection. A diagnosis of latent TB infection is made if a person has a positive TB test result and a medical evaluation does not indicate TB disease. The decision about treatment for latent TB infection will be based on a person's chances of developing TB disease by considering their risk factors. Diagnosis of tuberculosis disease. TB disease is diagnosed by medical history, physical examination, chest X-ray, and other laboratory tests. TB disease is treated by taking several drugs as recommended by a healthcare provider. TB disease should be suspected in persons who have any of the following symptoms: unexplained weight loss, loss of appetite, night sweats, fever, fatigue. If TB disease is in the lungs, pulmonary, symptoms may include coughing for longer than 3 weeks, hemoptysis, coughing up blood, chest pain. If TB disease is in other parts of the body, extrapulmonary, symptoms will depend on the area affected.
Complete medical evaluation and diagnosis of tuberculosis disease.
People suspected of having TB disease should be referred for a complete medical evaluation, which will include the following: medical history. Clinicians should ask about the patient's history of TB exposure, infection, or disease. It is also important to consider demographic factors, example, country of origin, age, ethnic or racial group, occupation, that may increase the patient's risk for exposure to TB or to drug-resistant TB. Also, clinicians should determine whether the patient has medical conditions, such as HIV infection or diabetes, that increase the risk of latent TB infection progressing to TB disease. Physical examination. A physical exam can provide valuable information about the patient's overall condition and other factors that may affect how TB is treated, such as HIV infection or other illnesses. Test for TB infection. The Mantoux tuberculin skin test, also known as TST, or the TB blood test, can be used to test for Mycobacterium tuberculosis infection. additional tests are required to confirm TB disease. Chest radiograph. A posterior-anterior chest radiograph is used to detect chest abnormalities. Lesions may appear anywhere in the lungs and may differ in size, shape, density, and cavitation. These abnormalities may suggest TB, but cannot be used to definitively diagnose TB. However, a chest radiograph may be used to rule out the possibility of pulmonary TB in a person who has had a positive reaction to a TST or TB blood test and no symptoms of disease. Diagnostic microbiology. The presence of acid-fast bacilli, in short AFB, on a sputum smear or other specimen often indicates TB disease. Acid-fast microscopy is easy and quick, but it does not confirm a diagnosis of TB because some acid-fast bacilli are not M. tuberculosis. Therefore, a culture is done on all initial samples to confirm the diagnosis. However, a positive culture is not always necessary to begin or continue treatment for TB. A positive culture for M. tuberculosis confirms the diagnosis of TB disease. Culture examinations should be completed on all specimens, regardless of AFB smear results. Laboratories should report positive results on smears and cultures within 24 hours by telephone or fax to the primary healthcare provider and to the state or local TB control program, as required by law. Drug resistance. For all patients, the initial M. tuberculosis isolate should be tested for drug resistance. It is crucial to identify drug resistance as early as possible to ensure effective treatment. Drug susceptibility patterns should be repeated for patients who do not respond adequately to treatment or who have positive culture results despite 3 months of therapy. Susceptibility results from laboratories should be promptly reported to the primary healthcare provider and to the state or local TB control program. Treatment. Deciding when to treat latent TB infection. Not everyone infected with TB bacteria becomes sick. As a result, 2 TB-related conditions exist: latent TB infection and TB disease. Both latent TB infection and TB disease can be treated. Without treatment, latent TB infection can progress to TB disease. If not treated properly, TB disease can be fatal. People with latent TB infection do not have symptoms, and they cannot spread TB bacteria to others. However, if latent TB bacteria become active in the body and multiply, the person will go from having latent TB infection to being sick with TB disease. For this reason, people with latent TB infection should be treated to prevent them from developing TB disease. Treatment of latent TB infection is essential to controlling TB because it substantially reduces the risk that latent TB infection will progress to TB disease. The global prevalence of latent TB infection estimation shows 1.7 billion in 2014. Without treatment, on average 1 in 10 people with latent TB infection will get sick with TB disease in the future. The risk is higher for people with HIV, diabetes, or other conditions that affect the immune system. More than 80% of people who get sick with TB disease in each year get sick from untreated latent TB infection. Treatment of latent TB infection should start after excluding the possibility of TB disease.
Priority for latent TB infection treatment.
Groups who should be given high priority for latent TB infection treatment include people with a positive TB blood test, interferon gamma release assay or IGRA, people with a tuberculin skin test, TST, reaction of 5 or more millimeters who are HIV infected persons. Recent contacts to a patient with active TB disease. Persons with fibrotic changes on chest radiograph consistent with old TB. Organ transplant recipients. Persons who are immunosuppressed for other reasons, for examples, taking the equivalent of greater than or equal to 15 mg/day of prednisone for 1 month or longer, taking TNF-alpha antagonists. People with ATST reaction of 10 or more millimeters who are from countries where TB is common, including Mexico, the Philippines, Vietnam, India, China, Haiti, and Guatemala, or other countries with high rates of TB. Of note, people born in Canada, Australia, New Zealand, or Western and Northern European countries are not considered at high risk for TB infection, unless they spend time in a country with a high rate of TB. Injection drug users. Residents and employees of high-risk congregate settings, for example, correctional facilities, nursing homes, homeless shelters, hospitals, and other healthcare facilities. Mycobacteriology laboratory personnel. Children under 4 years of age, or children and adolescents exposed to adults in high-risk categories. Persons with no known risk factors for TB may be considered for treatment of LTBI if they have either a positive IGRA result or if their reaction to the TST is 15 mm or larger. However, targeted TB testing programs should only be conducted among high-risk groups. All testing activities should be accompanied by a plan for follow-up care for persons with latent TB infection or disease. As of 2018, there are 4 CDC recommended treatment regimens for latent TB infection that use isoniazid, INH, rifapentine, RPT, and or rifampin, RIF. All the regimens are effective. Healthcare providers should prescribe the more convenient shorter regimens, when possible. Patients are more likely to complete shorter treatment regimens. Treatment must be modified if the patient is a contact of an individual with drug-resistant TB disease. Consultation with a TB expert is advised if the known source of TB infection has drug-resistant TB. Treatment regimens for latent TB infection. There are several treatment regimens recommended in the United States for latent TB infection. The medications used to treat latent TB infection include the following: isoniazid, INH, rifapentine, RPT, and rifampin, RIF. These medications are used on their own or in combination. CDC and the National Tuberculosis Controllers Association, NTCA, preferentially recommend short-course, rifampicin-based, 3 or 4 month latent TB infection treatment regimens over 6 or 9 month isoniazid monotherapy. Treatment for TB disease. When TB bacteria become active, multiplying in the body, and the immune system can't stop the bacteria from growing, this is called TB disease. TB disease will make a person sick. People with TB disease may spread the bacteria to people with whom they spend many hours. It is very important that people who have TB disease are treated, finish the medicine, and take the drugs exactly as prescribed. If they stop taking the drugs too soon, they can become sick again. If they do not take the drugs correctly, the TB bacteria that are still alive may become resistant to those drugs. TB that is resistant to drugs is harder and more expensive to treat. TB disease can be treated by taking several drugs for 6 to 9 months. There are 10 drugs currently approved by the US Food and Drug Administration, FDA, for treating TB. Of the approved drugs, The first-line anti-TB agents that form the core of treatment regimens are isoniazid, INH, rifampin, RIF, ethambutol, EMB, and pyrazinamide, PZA. Adverse events. Patients on treatment for latent TB infection, LTBI, or TB disease should report any signs and symptoms of adverse drug reactions to their healthcare provider, including unexplained loss of appetite, nausea or vomiting, brown urine asterisk, or jaundice, that is yellowing of skin or eyes, persistent tingling, numbness, or burning of hands or feet, persistent weakness, fatigue, fever, or abdominal tenderness, easy bruising or bleeding, blurred vision or changed vision. Asterisk patients taking rifampin, RIF, or rifapentine, RPT, should be informed that they will notice an orange discoloration of urine and possibly other body fluids. This is normal.
Current medications to avoid drug interactions.
Symptoms and complications associated with active pulmonary TB and their interactions with each other. Active pulmonary TB typically involves local symptoms related to the site of infection, that is the lungs, although various systemic symptoms and complications involving the entire body also occur.
Current medications to avoid drug interactions.
Patients should provide a list of current medications to avoid drug interactions. Some interactions to note. Isoniazid, INH, increases blood levels of phenytoin, dilantin, and disulfiram, and abuse. RIF and RPT decrease blood levels of many drugs including oral contraceptives, warfarin and some other anticoagulants, blood thinners, sulfonylureas, used for diabetes, and methadone. RIF and RPT are contraindicated in HIV-infected individuals being treated with protease inhibitors, PIs, and most non-nucleoside reverse transcriptase inhibitors, NNRTIs.
Steps to be considered during drug adverse event.
Healthcare providers treating patients with the combination regimen of isoniazid and rifapentine in 12 once-weekly doses, 3 HP, should inform the patient, parents, legal guardians of pediatric patient, about possible adverse effects and instruct them to seek medical attention when symptoms of possible adverse effects first appear. Conduct monthly evaluations for the findings of treatment-associated adverse events, e.g., symptoms suggestive of systemic drug reactions, loss of appetite, vomiting, yellow eyes, tenderness of the liver, easy bruising, rash. Order baseline liver chemistry blood tests, at least alanine or aspartate aminotransferase, ALT or AST, respectively, for patients with specific conditions, HIV infection, liver disorders, postpartum period, less than or equal to 3 months after delivery, regular alcohol usage, injection drug usage, or taking medications with known possible interactions with either isoniazid or rifapentine. Consider a baseline liver chemistry blood test for older patients on an individual basis, especially for those taking medications for chronic medical conditions. Conduct blood tests at the next clinical visit for patients whose baseline testing is abnormal and for others at risk for liver disease. Discontinue 3 HP if a serum ALT-AST concentration is greater than or equal to 5 times the upper limit of normal in the absence of symptoms, or greater than or equal to 3 times the upper limit of normal in the presence of symptoms. Be vigilant for drug hypersensitivity reactions. particularly hypotension or thrombocytopenia. In case of a possible severe adverse reaction, for example, hypotension requiring intravenous fluid support, discontinue 3-HP and provide supportive medical care. In case of mild to moderate adverse reaction, for example, dizziness, use conservative management, for example, treat dizziness with rest, oral fluids, conduct clinical and laboratory monitoring, and consider continuing 3-HP treatment under observation. Treatment of LTBI and TB for persons with HIV. People with HIV who also have either latent TB infection or TB disease can be treated effectively. The first step is to ensure that people with HIV are tested for TB infection. If found to have TB infection, further tests are needed to rule out TB disease. The next step is to start treatment for latent TB infection or TB disease based on test results. Fortunately, there are several treatment options for people living with HIV who also have latent TB infection or TB disease. Consult with your healthcare provider or state or local health department for treatment options. Latent TB infection and HIV. Someone with untreated latent TB infection and HIV infection is much more likely to develop TB disease during his or her lifetime than someone without HIV infection. There are several effective latent TB treatment regimens available for people with HIV. Healthcare providers should prescribe the more convenient shorter regimens, when possible, as patients are more likely to complete shorter treatment regimens. 12 weeks of once-weekly isoniazid and rifapentine, 3-HP, given by self-administered therapy or directly observed therapy, is the newest CDC-recommended treatment regimen for persons with latent TB infection and HIV and who are taking antiretroviral medications with acceptable drug-drug interactions with rifapentine. 4 months of daily rifampin is another treatment option. This regimen should not be used in people with HIV who are taking some combinations of antiretroviral therapy. In situations where rifampin cannot be used, sometimes another drug, rifabutin, may be substituted. For those taking antiretroviral medications with clinically significant drug interactions with once-weekly rifapentine or daily rifampin, 9 months of daily isoniazid is an alternative treatment. Treatment of tuberculosis disease in adults infected with HIV. The recommended treatment of TB disease in adults infected with HIV is a 6-month daily regimen consisting of an intensive phase of isoniazid, INH, rifampicin, pyrazinamide, PZA, and ethambutol, EMB, for the first 2 months. A continuation phase of INH and a rifampicin for the last 4 months. Once weekly INH and rifapentine in the continuation phase should not be used in any patient infected with HIV. 6 months should be considered the minimum duration of treatment for adults with HIV, even for patients with culture-negative TB. In the uncommon situation in which HIV-infected patients do not receive antiretroviral therapy during TB treatment, prolonging treatment to 9 months, extend continuation phase to 7 months, is recommended. Prolonging treatment to 9 months, extend continuation phase to 7 months, for HIV-infected patients with delayed response to therapy, for example, culture positive after 2 months of treatment, should be considered.
Treatment of TB disease in adults infected with HIV.
Drug-resistant TB and HIV. Treatment of drug-resistant TB in persons with HIV infection is the same as for patients without HIV. However, management of HIV-related TB requires expertise in the management of both HIV and TB. Antiretroviral therapy during TB treatment. For persons with HIV who are not already on ART, treatment for HIV should be initiated during treatment for TB disease, rather than at the end, to improve outcomes among TB patients co-infected with HIV. Antiretroviral therapy should ideally be initiated within the first 2 weeks of TB treatment for patients with CD4 cell counts 50 mm3 and by 8 to 12 weeks of TB treatment initiation for patients with CD4 cell counts greater than or equal to 50 mm3. An important exception is HIV-infected patients with TB meningitis, in whom antiretroviral therapy should not be initiated in the first 8 weeks of anti-tuberculosis therapy. Drug interactions. Rifampicins, a category of drugs for TB disease and latent TB infection treatment, can interact with certain medicines, antiretrovirals, used to treat HIV. One concern is the interaction of rifampin, RIF, with certain antiretroviral agents, some protease inhibitors, PIs, and non-nucleoside reverse transcriptase inhibitors, NRTIs. Rifabutin, which has fewer problematic drug interactions, may be used as an alternative to RIF for HIV-infected patients. As new antiretroviral agents and more pharmacokinetic data become available, these recommendations on managing interactions are likely to be modified. Visit Managing Drug Interactions in the Treatment of HIV-Related Tuberculosis and Guidelines for the Use of Antiretroviral Agents in HIV-1 Infected Adults and Adolescents. External icon for the most recent recommendations. Case Management. Directly observed therapy, and other adherence promoting strategies should be used in all patients with HIV-related TB. The care for HIV-related TB should be provided by, or in consultation with, experts in management of both TB and HIV. The care for persons with HIV-related TB should include close attention to adherence to both regimens of TB and antiretroviral treatment, drug-drug interactions, paradoxical reaction or immune reconstitution, inflammatory syndrome, IRIS, side effects for all drugs used, and the possibility of TB treatment failure or relapse. Treatment for tuberculosis disease and pregnancy. Untreated tuberculosis disease represents a greater hazard to a pregnant woman and her fetus than does its treatment. Treatment should be initiated whenever the probability of TB is moderate to high. Infants born to women with untreated TB may be of lower birth weight than those born to women without TB and, in rare circumstances, the infant may be born with TB. Although the drugs used in the initial treatment regimen for TB cross the placenta, they do not appear to have harmful effects on the fetus. Treatment for latent TB infection and pregnancy. For most pregnant women, treatment for latent TB infection can be delayed until 2-3 months postpartum to avoid administering unnecessary medication during pregnancy. For women who are at high risk for progression from latent TB infection to TB disease, especially those who are a recent contact of someone with infectious TB disease, treatment for latent TB infection should not be delayed on the basis of pregnancy alone, even during the first trimester. Tuberculosis treatment regimens for pregnant women. Diagnosis. Treatment. Latent TB infection. 4-month daily regimen of rifampin, RIF, 4R. 3-month daily regimen of isoniazid, INH, and RIF 3HR. 6 or 9 month daily regimen of INH, 6H or 9H, with pyridoxine, vitamin B6, supplementation. The 3-month weekly INH and rifapentine, 3HP, regimen is not recommended for pregnant women or women expecting to become pregnant during the treatment period because its safety during pregnancy has not been studied. TB disease. The preferred initial treatment regimen is INH, rifampin, RIF, and ethambutol, EMB, daily for 2 months, followed by INH and RIF daily, or twice weekly for 7 months, for a total of 9 months of treatment. Streptomycin should not be used because it has been shown to have harmful effects on the fetus. Pyrazinamide, PZA, is not recommended to be used because its effect on the fetus is unknown. HIV-related TB disease. Treatment of TB disease for pregnant women co-infected with HIV should be the same as for non-pregnant women, but with attention given to additional considerations. Treatment of tuberculosis disease in pregnancy, contraindications. The following anti-tuberculosis drugs are contraindicated in pregnant women: streptomycin, kanamycin, amikacin, capreomycin, fluoroquinolones. Drug-resistant TB. Pregnant women who are being treated for drug-resistant TB should receive counseling concerning the risk to the fetus because of the known and unknown risks of second-line anti-tuberculosis drugs. Breastfeeding. Breastfeeding should not be discouraged for women being treated with the first-line anti-tuberculosis drugs because the concentrations of these drugs in breast milk are too small to produce toxicity in the nursing newborn. For the same reason, drugs in breast milk are not an effective treatment for TB disease or latent TB infection in a nursing infant. Breastfeeding women taking INH should also take pyridoxine, vitamin B6, supplementation. RIF can cause orange discoloration of body fluids, including breast milk. Orange discoloration of body fluids is expected and harmless. There currently is not enough data to indicate whether the 3HP regimen is safe for women to take while breastfeeding. Treatment of tuberculosis disease in children. Once infected with TB bacteria, children are more likely than adults to get sick with TB disease and to get sick more quickly than adults. In comparison to children, TB disease in adults is usually due to past TB infection that becomes active years later, when a person's immune system becomes weak for some reason, example, HIV infection, diabetes. A pediatric TB expert should be involved in the treatment of TB in children and in the management of infants, young children, and immunocompromised children who have been exposed to someone with infectious TB disease. It is very important that children or anyone being treated for latent TB infection or TB disease take the drugs exactly as instructed by the doctor and finish the medicine.
Latent TB infection and tuberculosis disease treatment for children.
LTBI treatment for children. Treatment is recommended for children with latent TB infection to prevent them from developing TB disease. Infants, young children, and immunocompromised children with latent TB infection or children in close contact with someone with infectious TB disease require special consideration because they are at increased risk for getting TB disease. Consultation with a pediatric TB expert is recommended before treatment begins. Children over 2 years of age can be treated for latent TB infection with once-weekly isoniazid rifapentine for 12 weeks. Alternative treatments for latent TB infection in children include 4 months of daily rifampin or 9 months of daily isoniazid. The regimens are equally acceptable. However, healthcare providers should prescribe the more convenient shorter regimens when possible. Patients are more likely to complete shorter treatment regimens. TB disease treatment for children. TB disease is treated by taking several anti-TB medicines for 6 to 9 months. It is important to note that if a child stops taking the drugs before completion, the child can become sick again. If drugs are not taken correctly, the bacteria that are still alive may become resistant to those drugs. TB that is resistant to drugs is harder and more expensive to treat, and treatment lasts much longer, up to 18 to 24 months. Drug-resistant tuberculosis. Tuberculosis, TB, is a disease caused by bacteria that are spread from person to person through the air. TB usually affects the lungs, but it can also affect other parts of the body, such as the brain, the kidneys, or the spine. In most cases, TB is treatable and curable. However, people with TB can die if they do not get proper treatment. Sometimes drug-resistant TB occurs when bacteria become resistant to the drugs used to treat TB. This means that the drug can no longer kill the TB bacteria. Drug-resistant TB, DRTB, is spread the same way that drug-susceptible TB is spread. TB is spread through the air from one person to another. The TB bacteria are put into the air when a person with TB disease of the lungs or throat coughs, sneezes, speaks, or sings. People nearby may breathe in these bacteria and become infected. Causes of drug-resistant tuberculosis. Drug-resistant TB can occur when the drugs used to treat TB are misused or mismanaged. Examples of misuse or mismanagement include: people do not complete the full course of TB treatment. Healthcare providers prescribe the wrong treatment, the wrong dose or length of time. Drugs for proper treatment are not available. Drugs are of poor quality. Drug-resistant TB is more common in people who do not take their TB drugs regularly, do not take all of their TB drugs, develop TB disease again after being treated for TB disease in the past, come from areas of the world where drug-resistant TB is common, have spent time with someone known to have drug-resistant TB disease. Types of drug-resistant tuberculosis. Monoresistant tuberculosis, Mycobacterium tuberculosis, organisms resistant to any first-line anti-tuberculosis drug. Polyresistant tuberculosis, resistance to more than one first-line anti-TB drug, other than both isoniazid and rifampicin. Rifampicin-resistant tuberculosis, RRTB, Mycobacterium tuberculosis resistant to rifampicin. Patients with RRTB are eligible to be treated with the MDR-TB regimen.
Multidrug-resistant TB, MDR-TB. Multidrug-resistant TB, MDR-TB. Multidrug-resistant TB, MDR-TB, is caused by TB bacteria that is resistant to at least isoniazid and rifampin, the two most potent TB drugs. These drugs are used to treat all persons with TB disease. TB experts should be consulted in the treatment of MDR-TB. Extensively drug-resistant TB, XDR-TB. Extensively drug-resistant TB, XDR-TB, is a rare type of MDR-TB that is resistant to isoniazid and rifampin, plus any fluoroquinolone and at least one of 3 injectable second-line drugs such as amikacin, kanamycin, or capreomycin. Because XDR-TB is resistant to the most potent TB drugs, patients are left with treatment options that are much less effective. XDR-TB is of special concern for people with HIV infection or other conditions that can weaken the immune system. These people are more likely to develop TB disease once they are infected, and also have a higher risk of death once they develop TB. TB experts should be consulted in the treatment of XDR-TB. Prevention and treatment of drug-resistant tuberculosis.
Prevention of drug-resistant tuberculosis. The most important way to prevent the spread of drug-resistant TB is to take all TB drugs exactly as prescribed by the healthcare provider. No doses should be missed and treatment should not be stopped early. People receiving treatment for TB disease should tell their healthcare provider if they are having trouble taking the drugs. Healthcare providers can help prevent drug-resistant TB by quickly diagnosing cases, following recommended treatment guidelines, monitoring patients' response to treatment, and making sure therapy is completed. Another way to prevent getting drug-resistant TB is to avoid exposure to known drug-resistant TB patients in close or crowded places such as hospitals, prisons, or homeless shelters. People who work in hospitals or healthcare settings where TB patients are likely to be seen should consult infection control or occupational health experts. Treatment of drug-resistant TB. Drug-resistant TB is caused by TB bacteria that are resistant to at least one first-line anti-TB drug. Multidrug-resistant TB, MDR-TB, is resistant to more than one anti-TB drug and at least isoniazid, INH, and rifampin, RIF. Extensively drug-resistant TB, XDR-TB, is a rare type of MDR-TB that is resistant to isoniazid and rifampin, plus any fluoroquinolone and at least one of 3 injectable second-line drugs such as amikacin, kanamycin, or capreomycin. Treating and curing drug-resistant TB is complicated. Inappropriate management can have life-threatening results. Drug-resistant TB should be managed by or in close consultation with an expert in the disease. I hope this video will be extremely useful and thank you so much for watching this video. Kindly click the like button in case you feel useful and give your valuable comments for better improvement. Please subscribe GHEIL Forum channel and share all our video links to your friends, colleagues, people who work in the development and healthcare sectors. Once again, thank you so much.